Welcome to This Week in Neurology. This week we're covering 10 notable papers spanning cerebrovascular disease and hemorrhage management, antibody-mediated central nervous system disease, and the biology and prognostication of neurodegeneration, with a stop along the way in sleep and autonomic medicine. Let's dive in. We'll start with the cerebrovascular papers, where 3 publications touch on decisions you make in the acute phase and decades afterwards. In stroke, the American Heart Association has issued a science advisory on minimally invasive surgical evacuation of supratentorial spontaneous intracerebral hemorrhage, led by Wolf and colleagues. This is a genuine shift in posture. For decades, surgery for spontaneous intracerebral hemorrhage was largely abandoned outside of life-saving decompression because open craniotomy trials showed procedural risk without functional benefit. The advisory synthesizes the randomized evidence for minimally invasive techniques and concludes that these approaches now merit consideration in selected patients, particularly those with lobar hemorrhage, with attention to patient selection, the care pathway, and surgical technique. The practical implication is that in a patient with a moderate volume lobar clot, a surgical conversation should now happen early rather than not at all, and if your hospital does not offer minimally invasive evacuation, you need to know where transfer is possible and within what time window. Alongside that, GE and colleagues report a post-hoc analysis of the Enchanted trial, also in stroke, asking whether body weight changes the calculus of low-dose versus standard-dose alteplase. 2. Is not this see reference list. Across more than 3,000 patients in the dose comparison, body weight did not modify the relative effects of low-dose versus standard-dose alteplase on functional recovery, on death, or on symptomatic intracerebral hemorrhage. So the lingering intuition that heavier patients might be underdosed at 0.6 milligrams per kilogram or that lighter patients might bleed more at 0.9 is not supported. What the analysis did show, in the full cohort of nearly 4,500 patients, is that body weight itself is prognostic in a nonlinear way, with an inflection around 74 kilograms. Patients below that weight had roughly 40% higher odds of a poor functional outcome and a higher risk of death, but crucially no excess symptomatic hemorrhage. Low weight is therefore a marker of frailty and vulnerability, not a signal to reduce the thrombolytic dose. The third cerebrovascular paper looks much further downstream. In JAMA Neurology, Alpquist and colleagues followed young survivors of aneurysmal subarachnoid hemorrhage using a Stockholm regional register cross-linked to national health and death registers, with radiological follow-up extending as far as 57 years. Among 544 survivors who were under 40 at their index bleed, roughly 1 in 5 developed a new aneurysm over nearly 14,000 person years, and the cumulative incidence reached about 30% at 40 years, with no plateau. Female sex, smoking, and a family history each roughly doubled the hazard, and smoking cessation was associated with lower risk in a dose-dependent fashion. 23 of the new aneurysms ruptured, and a third of those ruptures happened more than 20 years after the index event. No ruptures occurred in patients under systematic surveillance. For a young survivor sitting in your clinic, this argues for lifelong imaging follow-up rather than the 5 or 10-year horizon many services default to, and it makes smoking cessation the single most concrete preventative lever you have. Moving to antibody-mediated central nervous system disease, 2 papers address the same clinical space from opposite ends. In Neurology, Hakohen and colleagues reviewed de-escalating and discontinuing immunotherapy in aquaporin 4 antibody neuromyelitis optica spectrum disorder, and in myelin oligodendrocyte glycoprotein antibody-associated disease. Their message separates the 2 conditions sharply. In aquaporin 4 antibody disease, relapses are severe and disabling. Observational data consistently show high reactivation risk after withdrawal, and discontinuation is never recommended. Cautious de-escalation has been reported in selected patients in prolonged remission, but relapse risk persists. In NUG antibody disease, the picture is different. Many patients, especially children, are monophasic. Adult relapse risk declines after several years, and cohort data suggest discontinuation may be feasible after 2 to 5 years of remission, particularly in patients who become seronegative. For seronegative neuromyelitis optica spectrum disorder, the evidence base is thin, and any suggestion of stopping after 5 years of stability rests on expert opinion alone. Monitoring with MRI, optical coherence tomography, and fluid biomarkers is promising, but none is validated for routine use. Complementing that, Science Translational Medicine carries work from Wang and colleagues identifying antibodies against MLC1, an astrocytic end-foot membrane protein, as a new autoantigen. Screening 297 patients with inflammatory autoimmune central nervous system disease, they found 4 who were MLC1 antibody positive. All 4 had overlapping, atypical features of multiple sclerosis and neuromyelitis optica spectrum disorder, and all were negative for aquaporin 4 and MOG antibodies. A monoclonal MLC1 antibody induced astrocytopathy in mouse cerebellar slice cultures and in a rat encephalitis model, supporting pathogenicity rather than bystander status. It's a rare antibody, but it chips away at the seronegative category that the Neurology review flags as the hardest to manage. On neurodegeneration, 3 papers approach the problem at different scales. In JAMA Neurology, Benatar and colleagues propose reconceptualizing TDP-43-associated disease around its pathobiology rather than its clinical phenotype. TDP-43 pathology underlies limbic predominant age-related encephalopathy, most amyotrophic lateral sclerosis, inclusion body myositis, multisystem proteinopathy, and roughly half of frontotemporal dementia. Their argument is that terms like ALS, FTD, and late should describe phenotypic expression of a shared underlying biology that begins pre-symptomatically, which is the framework needed to build biomarkers and to design trials that intervene before symptoms. Prognostication at the individual level is exactly what Paranjos and colleagues address in Neurology. In 130 patients with biomarker-supported early-onset Alzheimer's disease at the mild cognitive impairment stage. Baseline atrophy within a parietemporal early-onset Alzheimer's signature predicted faster progression to dementia, with each standard deviation of additional atrophy raising the hazard by about a quarter, and adding the imaging measure improved prediction beyond baseline clinical severity alone. That's a structural MRI metric with plausible use for counseling and for trial stratification in a group where progression is notoriously variable. And in the BMJ, Dineshvar and colleagues quantified chronic traumatic encephalopathy at death among former National Football League players. Of 1712 players who died between 2008 and 2021, about a fifth donated their brains, and of those donors, 93% had chronic traumatic encephalopathy. Because brain donation is not random, the honest answer is a range. Prevalence at death somewhere between about 19% and essentially universal. And for the years 2016 to 2021, when donation was most frequent, at least about a quarter. Among donors, stage 4 disease was associated with roughly 44% higher risk of clinician-diagnosed dementia, and only about 40% of donors with dementia had neurodegenerative disease listed anywhere on the death certificate, a reminder that death certificate data substantially undercount this. Finally, 2 papers on sleep and autonomic function. In the Lancet Neurology, Platzi and colleagues report the Vibrance-1 Phase 2 trial of alixorexton, an oral selective orexin-2 receptor agonist, in 92 adults with narcolepsy type 1 across 46 sites. The effect on the maintenance of wakefulness test was large, placebo-corrected improvements in mean sleep latency of roughly 22 to 26 minutes across the 4, 6, and 8 milligram doses at 6 weeks, with improvements in daytime sleepiness and cataplexy as well. Tolerability was reasonable, but the on-target effects are real and worth counseling about. Urinary frequency in more than half of treated participants, insomnia in around a quarter, salivary hypersecretion in a quarter, plus urinary urgency and blurred vision. This is Phase 2, 6 weeks, and small, so hepatic safety and durability remain for Phase 3. Then in JAMA, Chung and Raj review postural orthostatic tachycardia syndrome. It affects an estimated 1 in 1,000 to 1 in 100 people in the United States, about 90% of them female, with peak onset in the teens and 20s, and in a survey of nearly 5,000 patients, the median diagnostic delay was 2 years, and around 70% reported substantial functional impairment. 30 to 40% of cases begin within 3 months of an infection. Diagnosis requires a sustained heart rate rise of at least 30 beats per minute on standing without orthostatic hypotension, after excluding thyroid disease, anemia, medication effects, and cardiac causes. First-line management is non-pharmacological. Fluid and sodium loading, lower body compression, and structured supervised aerobic training with beta blockers, ivabradine, midodrine, fludrocortisone, and pyridostigmine individualized, all on a thin randomized evidence base. If you only have time for one paper this week, make it the American Heart Association Science Advisory in Stroke on minimally invasive evacuation of intracerebral hemorrhage. It changes the default answer to a question you are asked at the bedside. Is there anything surgical to offer? And it should reshape your local referral pathway. Here are the key takeaways from this week in neurology. Surgery is back on the table for selected supratentorial intracerebral hemorrhage, particularly lobar clots, so know your minimally invasive referral route. Body weight should not change your alteplase dosing, but low body weight flags a patient at higher risk of a poor outcome for reasons other than bleeding. Young subarachnoid hemorrhage survivors need lifelong aneurysm surveillance and aggressive smoking cessation because the risk of new aneurysms never plateaus. In antibody-mediated disease, never stop immunotherapy in aquaporin 4 positive disease. While thoughtful discontinuation may be reasonable in MOG antibody disease after sustained remission, especially with seroreversion. And in early onset Alzheimer's disease at the mild cognitive impairment stage, signature cortical atrophy on structural MRI adds prognostic information beyond the clinical picture alone. That's your roundup for This Week in Neurology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And think of one colleague in any specialty who never has time to keep up with the literature. Tell them about Audio Scholar, a free 10-minute weekly for every specialty, to listen to in any podcast app or to read at audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.